Those are the answers. Okay, we have 23. We at least have 29. I counted 29. Anybody having problems getting on? You don't want to play with me. 24. You can change the music to this, and I did it on my last class, and I played disco. This is not that exciting. You can. Here, let's see if we can do it mid-range. What's that? I know. Change music. What do you guys want? Fantasy, adventure, disco, funk, reggae, rhoda. I know we have a lot of musicians. Definitely disco. Is that disco? Okay, I lost a player. I had 24, now I have 23. Do you like the disco better? Yeah. You want to hear what fantasy sounds like?
Yeah, just like.
Yeah, me too. It's like orchestra, yeah, Disney. You hot? It is hot in here. And I think as the day goes on, it gets colder though. So. Oh, I think it's hot in the morning. Oh, you're absolutely right. Because there's reggae. It's just they changed the beat. I'm disappointed. Okay. You got cold because you were in the lab? In the lab? That's because Miss, oh no? Oh, in Elvis.
In the lab, we're actually doing something.
So you're, okay. All right, I'm losing people, so let's just do it. I think I made it big enough so you can see it. Okay. So we got a little bit of teaching to do here. 13 of you got the right answer. The right answer is to obtain the ordered cultures, blood, and sputum. So the people that said administer the ordered IV antibiotics, I would say that's probably the next best answer. But think through why you would want to do the culture prior to doing the antibiotic. We did the infection already. Anybody hand up? Say again?
It's too early, but it's because you want to make sure that you haven't messed up the blood and culture by the IV.
Okay. Right, so we want to make sure that we can find out, the healthcare providers need the information on what's the agent that's causing that pneumonia before we can treat it. Now, you're right, Elizabeth, we will, in practice, start them on a broad spectrum antibiotic. And once the culture and sensitivity comes back to tell us what that agent is, then that will direct the order for the antibiotic. It might be viral, so they won't get an antibiotic, but we'll always treat with a broad spectrum antibiotic to begin with. But it's real important to get that culture prior to starting the antibiotic. Get the client to radiology to order CT scan of chest. What's the thought process behind that? Yeah, and that's okay. And they'll probably definitely get an x-ray. So an x-ray is that diagnostic tool that when somebody comes in with pneumonia or any kind of gas exchange issues, x-ray is pretty cheap, pretty standard test to see what's going on in those lungs. So in pneumonia, what's going on in the lungs? Okay, so what's actually going on? What do you hear when someone has pneumonia? You put your stethoscope on. What do you hear? crackling. Ready? Oh, shoot, bad throw. Okay, crackling. Why do we hear crackling? Because of that fluid, right? So the pneumonia is actually, the term is inflammation of the lung parenchyma. What the heck? Parenchyma is actually the functional part of the lungs. So like Autumn said, where that gas exchange is taking place in those bronchioles, down at that alveoli, right? So you have inflammation, you have infection, and so you have a part of the lung, we call it a consolidation, where that gas exchange is not taking place, okay? Does that make sense? And again, it can be a bacteria when we would want an antibiotic. It could be a viral. A lot of people with COVID-19 are getting pneumonia that can be caused by that bacterium, right, by the coronavirus. Or it can be fungi or other kind of microorganisms, okay? Good? All right. And then nobody chose have the patient's care tech obtain a weight. Very good, very good. Okay, oh, blessing. What kind of chocolate do you like? Anything's fine. Right. All right, good catch. Okay, next question. Bacon, is it funny that bacon is right above the pig? Does anybody find that funny? Thank you for laughing, Laura. Okay, next question, true or false? So how you say that is bradypnea. Bradypnea. So what is bradypnea? Slow breathing. And it is not the most common sign for possible pulmonary embolism. Dyspnea is. What's dyspnea? Difficulty breathing. So dyspnea is actually a subjective finding. So it's that client saying, I'm having a hard time breathing. I can't breathe, right? With pulmonary embolism, I actually have a little video. I like the other one better, but this one's the only one that would come on this lovely thing. Check it out. I'm a big video girl.
It's called deep vein thrombosis, or DVT. DVT occurs in over 400,000 Americans a year. Complications occur when the clot breaks off and travels through the circulation system. When it reaches a blood vessel it cannot flow through, a blockage occurs. This is called an embolism. 90% of the time, it occurs in the lung. A pulmonary embolism is a life-threatening event.
So let's talk a little bit more about that, okay? When somebody is having a pulmonary embolus, they will have sudden difficulty breathing, sudden pleuritic, so that pleural cavity, pleural lining of the lung, that they'll have chest pain. They'll have tachypnea and tachycardia, which is a fast heart rate and a fast respiratory rate. They will cough. A lot of times they'll cough up blood. They will have anxiety, as you can imagine, because they're having this sudden difficulty breathing. They may be coughing up blood. And then sometimes they'll pass out, what they call syncope. When you put your stethoscope on the patient that has a pulmonary embolus, the area that is being blocked off, you won't be able to hear the lung sounds. Does that make sense? Because when you're listening to lung sounds, you're hearing that exchange, that gas exchange. The oxygen come in, the carbon dioxide go out. So if you have a situation like that where the clot has come up and blocked that area of the lung where the gas exchange is taking place, you won't be able to hear the air exchange. Does everybody understand that? So what are some causes? What might put somebody at more risk to have a pulmonary embolus? Anybody know?
Surgery, medication, or
Yep, surgery. What kind of medication are you thinking? Because I don't.
I can't think of one right now.
Okay. Surgery for sure.
Clotting disorders or obesity?
And yep. Smoking, yeah. Birth control, thank you. Actually, my roommate in college had a she didn't have a pulmonary embolism, but she ended up having a, why am I blanking on that? Not an aneurysm. She had a blood clot, but something else. She like had a stroke. Thank you. She had a stroke, and she was 21. And yeah, because of birth control. Thank you, thank you, thank you. Pregnancy, anybody that's in the bed for a long time, that immobility, those are risk factors of pulmonary embolism. What's that? In the car driving, yep. So my mom, whose birthday was yesterday, she just turned 79. I'm going to see her tomorrow. I'm very pumped. Yeah, yeah. What's that? Yeah. Woo. Okay. She fell down our steps at Christmas 2 years ago and broke her ribs. So as you can imagine, somebody with broken ribs doesn't take deep breaths, and we had to get her back home to Virginia. She wasn't allowed to fly because of that risk of a blood clot. Yep. Okay. Any other questions on that?
Is it the altitude?
Well, I think it's the altitude and not moving, right? So when we're driving, we can get her, we stop and got her up. Funny story, we gave her a little Ativan. And we didn't talk the entire 8 hours of driving. My husband's driving, and because anytime somebody would talk, she'd be like, what? Even with the Ativan.
Yeah.
She's a spunky lady. Okay, next question. Oh, the pig. Okay, you have to tell me who you are so you can get a piece of candy. Who's the pig? Way to go, Evan. Do you have preference? All right, I'm going to come up close. Yeah, I don't think I can. All right. We'll have to see who's baking. I hope that person gets up there so you two can meet. All right, next question. What does the nurse expect to see as the major clinical symptom of a client with COPD? Okay, so I am okay that a lot of you picked tachypnea because I feel like your thought process was they're struggling to breathe and their respiratory rate's going to be up. Is that correct? So that's not an incorrect answer because they probably will have tachypnea. The what do they call primary symptoms of COPD is going to be sputum, cough, and dyspnea. Because of that dyspnea and that cough and sputum, their heart rate or respiratory rate will be up. Okay, so that's okay. I kind of threw it in there on purpose. Fever, fever's more indicative of somebody who has an infection. So people that have COPD are very prone to pneumonia. So if somebody had COPD and pneumonia, they could potentially have a fever. And then bradycardia is a lower heart rate. You wouldn't have that until the patient progressed so far down the line where they actually were decompensating, all right? So think about the COPD pathophysiology, okay? We had a picture. Let me see if I can go. I don't know if I can go back. Will let me go back? Oh, thank you. Oh, beautiful. Okay, so think about the pathophys when you're looking at someone's lungs. So here, the big picture, and up on the top is the healthy airway, okay? With COPD, see that lovely mucus or sputum coming out the airway? And look at how close or narrow that airway is, right? So just think about, I always like to explain it like a straw. So if your airways, your little bronchioles are like a straw, the more open they are, the pathway can go from air down to the alveoli to inflate those. Have you ever sucked on a straw like some of those like silicone ones and they collapse? Yeah? And then you can't suck the fluid in there. Same kind of situation, but reverse, right? So you can't get that oxygen. You can't get the airway. The airway's closing down, so you can't get that oxygen to the tissue where it needs to be. All right? Cough and sputum production for at least 3 months for 2 consecutive years is what we call the diagnostic term for chronic bronchitis. So with COPD, you have chronic bronchitis, emphysema, and asthma. Okay, those three exemplars that we're talking about are all kind of in that COPD umbrella. All right. So cool with that? Questions on that? Yeah, it's for 3 months in each of 2 consecutive years. And it's usually worse in the winter, obviously. Good question. All right, so let's do the next one. Are y'all having just so much fun? Yes, Miss Dawn. Thank you. So much fun. Just with your class is so fun. All right, I'm a pediatric nurse by trade. We like to play. Okay. Oh, okay. Who's the shades? Who's the cool dude? What candy would you like? Your choices are Kit Kats. All right. Next question. Oh, I dropped one. Yeah, I will teach you. Okay. Next question. What is the best non-invasive approach to monitor oxygen saturation? Yay! So I do not mind that one person picked the respiratory rate, because when you are, the correct answer is the pulse oximetry, right? So when you're assessing somebody in a respiratory focused assessment, you are putting that pulse oximetry on their finger so you get an oxygen saturation number. Normal, 95 to 100 on a person that doesn't have chronic disorders. Somebody that has COPD, we like it above 90, or we'll accept it above 90. But you are also not only putting that pulse oximetry on them, you're looking at them. You're trying to see what kind of work of breathing. Are they having retractions where they're forcibly trying to breathe? Are they leaning forward, doing this tripod position where they're really trying to compensate and get oxygen in because their body's telling them they don't have enough? You're counting the respiratory rate. You're also getting the heart rate. You're auscultating the lungs. I heard in your book there's like 5,300 places to auscultate, but you don't have to do that, right? So you want to auscultate and compare bilaterally, and I know they talked about that, so that when you're auscultating, you're listening to that airflow in and out of the bronchioles to tell us whether the patient is being oxygenated or the gas is exchanging at that alveoli, okay? But having said that, pulse oximetry is not perfect. There are a lot of situations where it can be inaccurate. Anybody have any examples? Nail polish can definitely hinder that, because what it's doing is it's picking up the hemoglobin, right? It's picking up what red blood cells, the oxygen's carried through the hemoglobin, and that impaired light is picking that up. So nail polish. What else possibly would give us an incorrect reading?
And I don't know, but I'm asking.
Yeah.
Somebody with like really cold skin, can I know that?
Absolutely. And so let's talk about that. Let's think about why that is. So somebody with really cold skin, extremities that are cold, are telling us, and I know you haven't had this topic yet, but what is that telling us about how well? Not a lot of perfusion getting to that extremity, right? Well, if we're not getting the oxygen and the blood down there, then yeah, it can be inaccurate. What else? Age can, yep. A lot of times, like if you have the tiny newborns, you know, it's hard to, they put them on their foot, they put them everywhere. Yeah, age can be an issue. Sometimes the machine just won't work, right? So one time, I don't know if I shared this with you guys yet. I must have been, I hope I was a new nurse. I was taking care of a patient and the oxygen saturation was low. The heart rate was out the roof. And it's not as good of a story. I should have probably made it up and said respiratory rate, but it was the heart rate. Then I called the provider and I'm like, oh my gosh, this baby's heart rate is like 210, which is really high for a baby. And she looks fine. I'm not sure what's going on. And the healthcare provider said, oh, wow. So when you put your stethoscope to the heart, to the chest wall to actually auscultate and count that number, what did you get? Oh, I just looked at my monitor. I literally was like, oh, that's not a good nursing assessment. So I say that I share my trials with you to say, always, always, always get that stethoscope on the chest, count the respiratory rate, look at the heart, or listen to the heart rate, look at the chest rise and fall, and don't depend too much on your machines, like the pulse ox. Which is more accurate, an ABG or a pulse ox? ABG. So why ABG? So why isn't ABG the correct answer here? Exactly. I was trying to get you thinking like those test questions, right? If it said invasive, then ABG would be the answer, right? So somebody that comes in some respiratory distress, depending on how ill they are, they might just monitor them with a pulse ox, or if they continue to decompensate, then we would get an ABG. An ABG, arterial blood gas, you guys will learn more about, but that tells us what the acid balance is and gives us a better picture of how they're oxygenating their tissues. Okay, great. I should have asked you then. It's on your test tomorrow. Excellent. All right. Where's Mark?
Oh, man.
What'd you do?
I don't want to give it away.
Ah. Okay. Give it away. Okay, so hypoxia is the term for low oxygen levels in the blood. Okay, hypoxia is low oxygen levels in the blood. Hypoxemia, remember your medical terminology, emia is in the blood. Oxy is in the tissues, emia is in the blood. Okay. Tell me a little bit about, so, okay, let's continue on. What about dyspnea? We already talked about that, difficulty breathing. What's ischemia? Okay. Yep. So ischemia is insufficient flow of blood to the tissues. And if a tissue area becomes ischemic, it can die because it's not getting that oxygen or blood. Good. Let's talk a little bit about what it looks like when somebody comes in with hypoxia. What are our early signs and our late signs of hypoxia? Which one is cyanosis? A late sign, right? So let's talk early first. So somebody comes in and has hypoxia, so they're going to, how are they going to breathe? Fast, thank you. How's their heart rate going to be? Up. So tachypnea, tachycardia. Big sign of hypoxia that a lot of people miss, and you need to focus in on it if it's an exam question, would be restlessness. Okay, restlessness is a very important sign in early hypoxia. Anxiety, confusion, because they're not getting that oxygen to their brain, and they're having a hard time breathing. What's their skin going to look like in early hypoxia? Not flushed. Pallor. It's going to be pale. It's got the mucous membranes are just going to look white. Okay. What about their blood pressure in early hypoxia? It's going to be high, right? Because they're trying to compensate. They're going to have hypertension. So they're going to have tachycardia, tachypnea. They're going to be restless. They're going to have pallor or pale skin, pale mucous membranes. They're going to have a high blood pressure, hypertension. And then the other thing I want to make sure you guys hear clear, they're going to be using those accessory muscles. So in babies and kids, we always see nasal flaring first. So their nose, and I have some videos to show you because I think it's much better than me trying to explain it. But nasal flaring, you could see retractions. Anybody ever see this? feel this? Okay, I'm going to show you a picture. Yeah, it's quite scary, right? Retractions, their muscles and their intercostal, you know, they're trying hard to get oxygen, right? So I'm trying to paint a picture for you. But when people get to the late stages of hypoxia, and it's important that you're able to distinguish because it's going to determine your interventions, they're going to look blue, cyanotic, somebody said earlier. They're going to have even more confusion, change in their mental status because that oxygen's not getting to the brain even more. They're going to have bradycardia, lower heart rate, lower blood pressure, hypotension, and then eventually they're going to have cardiac dysrhythmias because that heart muscle is not getting enough oxygen. Okay, you guys see that? Okay, all right, next question. Oh, God bless you. All right, who should I give candy to? Mark. Mark, what kind of candy do you eat candy?
Not really, but I'll give someone else.
All right, that's sweet of you. That's very kind. I know you might not eat candy.
Our hot sauce is sweet.
Right? Good catch. Did your mask have an Under Armour on it? Doesn't come out.
I don't know, this is the first day I wore it. It's, someone told me it's the most comfortable one, and so far they're right.
Are they right? Good. It looks comfortable. Okay, next question. Aging and oxygenation. God bless you. Very good, you guys. Very good, very good, very good. What's that?
Oh, no, I can't read.
Oh, it says older adults have diaphragms that move less efficiently, okay? So if you haven't noticed, we're trying to do this lifespan teaching in the concept-based curriculum. When an infant in the other age, not older adult, but in the infant stage, the infants are gonna breathe, so the reason number one is not correct is they breathe faster, all right? So you can have anywhere, a newborn can breathe anywhere from 30 to 60, okay? What's the adult norm? 12 to 20. So, and then as the child ages, it starts going down. So a toddler, and you don't need to know these numbers, but just for an example, 30 to 60 on the infant, 24 to 40 on the toddler, then 22 on the preschooler, and 18 to 30. You know, as they get older, adolescent is pretty much what an adult breathes, okay? Older adults, airways become less rigid, not more, they become more rigid, not less rigid, okay? And then infants are more prone for aspiration because of their shorter airway. I pulled up a different slide on the aging that Dr. Grayson did. I thought it was really good. And I'm going to put this on. Oh, that's all we did. That's not a good example. It's a very good picture. So with the older adults, guys, with the older adults, they have weaker respiratory muscles, which causes their coughing mechanism to be improved or to be weak, be inefficient, right? So they're not able to cough up that mucus that maybe you and I could. And then it would make them more prone to aspiration and pneumonia, right? Because then they can't get those secretions out of their lungs. They, a lot of times, older people, you'll see them kind of leaning forward with a kyphosis, yeah, you've seen, and then, or a barrel chest. So in health assessment, I know you guys talked about the AP versus transverse. Sometimes that's confusing. So AP is anterior to posterior versus transverse. So in a normal person, not an older adult, a normal person, it's going to be 1 to 2, 1 to 2. Does that make sense? But in somebody that has hyperinflation of their lungs, or their lungs are not as efficient because they're trying to get more oxygen over a long period of time, their body is more barrel shaped. So it's 1 to 1. Does that make sense? I always have a hard time with that 1 to 1, 1 to 2 thing. But if you think out kind of what it looks like, I think it helps. Questions on the aging adult? Yeah, it's hard to conceptualize. You got it, Jordan? You know what I mean? Yeah, Cheyenne? Y'all good? You can ask. I bet if you're asking the question, somebody else is too. Questions?
I just don't get the ratio thing completely.
So if I were to measure from here to here, let's say it was 10. From here to here, it'd be 20, twice as much, if I was normal, right? Twice as wide. So I'd be twice as wide transverse than forward, than from front to back. In the person who has COPD, emphysema, older adult, it's equal. So you don't see that half as big. You know, it's not twice as much in them, it's equal. You would measure it, it would be 20 and 20. Does that help?
Yes.
I think it's a hard concept to get unless you actually see it. I actually have a picture in a video that might show it a little bit better. We already did the pig, right? Someone else already did the pig. Where is Asia? Is it Asia? Did I say it wrong? Okay. Do you have a question, or will you just tell me where she was? So you get candy for that because that's really helpful. All right. Justin, aren't you glad you don't have to help me with collaborative? Okay, next question. Select the rescue medication that will be likely to be prescribed for someone having an asthma attack. Is this on your test tomorrow?
I hope not.
I hope not. Okay, so the correct answer is the beta-2 adrenergic agonists. And the example of that is albuterol, because it's a bronchodilator, right? So in asthma, remember the airways start constricting. Remember that straw? The airways start constricting. So to improve the oxygenation, we've got to open it up. And the way we open it up is by a bronchodilator like albuterol. The medication combined corticosteroid long-acting beta agonist is a medication that people that have asthma or COPD take on a routine basis, and it's called a maintenance med, or do you call it anything else? Maintenance. So you have two categories: your short-acting or rescue, and then your maintenance. Okay, so that maintenance is what's going to hopefully, the corticosteroid does what for inflammation? Reduces it, right? So the idea is that if they're taking that on a routine basis when they're not having an exacerbation, it's going to decrease that inflammation in the airway on a normal day. So they should take that routinely, and it's huge with patient education so they understand which inhaler does what and when they're supposed to take it, okay? When somebody comes in an asthma exacerbation, the first thing we're going to do is try to, we're going to assess them, right? We're going to put on their oxygen saturation probe. We're going to listen to them. We're going to do their respiratory rate. And then typically we're going to give an inhaler, and sometimes they will get a steroid, which will IV, or sometimes intramuscularly, but IV typically, to try to open up that airway, okay? Any questions on that? There is a table 24.4 in your text that talks about 24.4 is the controller long-term meds and 24.5 are the rescue meds. All right? Yeah. Oh goodness, let's see if I can. So Leukotriene is like a Singulair, and I honestly can't tell you exactly how that works. Does anybody know if that's on it? Anybody know how Singulair works? I'll look it up for you to see what, because we've got these awesome Picmonics. When we break, I think there is one in there, and I'll show it. But I'm not exactly sure how that works.
So what is a Leukotriene itself?
It's on something for
It's on Patho tomorrow?
Yeah, like not the modifier, but
But aren't the leukotrienes, and I can speak for them, but aren't the leukotrienes and prostaglandins the ones that, have to do with the,
mediator.
right, we don't know what, they have to do with the, they have to do with
But
the
we don't know what it
vascular
is.
stage, and they cause vaso.
Okay.
So like.
I'm gonna find that out for you.
flesh skin. I know what it does. I just don't
You know what it is, but you don't know what it is. Okay.
But aren't they?
Well, it'd be nice to know what it is, so that would help you know how it's modifier,
But
right?
the leukotrienes, the intraligens, is that what those are?
They're white blood cells that are modifiers to help the histamine get to where it's going, I believe. Or something with histamine and something with white blood cells.
When we take a break, I promise you, I'll look it up. Go ahead.
Sense of singular, the leukotriene modifier, because of the asthma.
Yeah. Yeah.
What
Yeah.
tables did you just say?
I'm sorry?
You just said table?
Oh, 24.4 and 24.5 talks about the different meds. But with asthma, you need to know that there's two approaches to treating it. One is avoiding or controlling those triggers that trigger the attack. And then if that doesn't work, then treating it pharmacologically, okay? I like the, oh, that's you. All right. Bless you. Did you get candy yet? You want another piece? Here you go. Because you're on the front row, I can throw these here. Okay. True or false? The extent of wheezing does not necessarily indicate the severity of the asthma attack. I don't know why you have so much time on this one. Maybe because of my video. So remember, wheezing is what you hear when that narrowing, when the airway starts to narrow in like asthma or COPD. Crackles, you can hear with COPD if there's the sputum and secretions, but you'll hear with pneumonia. Okay. All right, so I love that I asked this question because it's a concept I want to make sure you understand, okay? So remember, asthma exacerbation can go from mild to severe, all right? With someone that is having wheezing, it's telling that when we're listening, we're auscultating and we hear wheezing, it's telling us that their airway is constricting, the airway is narrowing, okay? As a person progresses, so I'm assessing my patient, I'm doing my albuterol, my beta-2 adrenergic agonist, I'm giving them steroids to decrease the inflammation, I'm giving them supplemental oxygen, and he's wheezing and he's wheezing. Sometimes you can even hear the wheezing without your stethoscope. Have you heard? You shake your head. You can, and I have some videos. Say again? Yeah, you can hear it sometimes without even putting your stethoscope on. However, if someone is having that severe of a asthma attack and then all of a sudden stops wheezing, what is that telling you?
They're probably not breathing.
They're definitely not breathing, not probably. It's completely constricted. There's nothing getting to the tissues. And if there's nothing getting to the tissues, that person's about to code. Okay, that person is about to, the respiratory rate is going to be down, completely gone. The heart rate's going to be down, completely gone. They're going to be blue. Remember those late signs of hypoxia, right? So that I just want to make sure that you understand that concept that just if someone is wheezing so badly and suddenly stops, that doesn't mean you did a great job. All right. Now, you might hear expiratory wheezing, inspiratory wheezing, and expiratory, and then as you treat them, you'll hear some scattered expiratory. Does that mean he's getting better or worse? Better, right? Because think about what's going on. So if they're wheezing on inspiration and expiration, they can't. It's extremely bad. If they're just wheezing on expiration occasionally, scattered, then they're getting some oxygen exchange. Get it? Okay. All right, true or false? I am starting to get the hang of this nursing school thing. I didn't hear that. What did you say? Oh, the honest answer. Okay, you guys, you are in week 4, right? Week 4. And you're stressed. I get that. I think you're doing a good job. I think you're kind of doing this number paddling doggy. We took my grandpup out on the lake this weekend. He had a little life jacket on, and we totally didn't get that life jacket was going to hold him up. He jumped in, but he felt like, that's how you guys feel. He was paddling so hard and scratched me to the end. All right. What I want to do now is answer any questions that you just have burning on the top of your head that I can tell you are so excited to ask me. All right, no questions. All right, that's what we're going to do. We're going to take about a 15-minute break. I'm going to run to my office and get something. And we don't need any more papers, you guys said, because I have 15 of these. I'm going to open up D2L, which will have, say again?
There's one more complete question. I don't know if that matters.
Oh. Let's see what it is. Oh, forgot I added this. What independent nursing actions will you provide to a client with impaired gas exchange? Okay. All right, I love that you guys answered it like that. Okay. The answer is auscultate lung sounds, assess respiratory rate. All right. Administering 3 liters of oxygen via nasal cannula. So what we teach you and what I believe to be true in the real world is that if someone comes into your facility and is experiencing dyspnea and tachycardia, tachypnea, they're pale, they're showing some early signs of hypoxia, you as a nurse are allowed to give them a little oxygen. What does that mean? Nasal cannula, 1 to 2 liters per minute, okay? Anything more, and then once you do that, then you get an order for it. Because oxygen definitely is a medication and you need an order. But we don't want to, the hospitals will have protocols that say, if a patient comes in like this, this is what you do. So I just wanted to clear that up. So you can give 1 to 2 liters of oxygen via nasal cannula without an order, but then you have to get an order, okay? Anything more than that, you really need to have an order, okay? So we'll be talking a good bit about titrating oxygen based on your assessment and the oxygenation, okay? So what that means is you'll see a healthcare provider order that looks something like this. It says maintain oxygen saturations to 95% or greater, okay? So what that means is you have an order to adjust your oxygen appropriately to get them at 95% on the pulse ox or greater, okay? So if you come in and they're on 2 liters of oxygen and their oxygen saturation is 90, with that order I just said, what do you do with the oxygen flow meter? Turn it up to what? The liters. So you're at 2 right now, turn them up to 3, and then assess. Turn them up to 3, assess, see if that's better. Mr. So-and-so, does that make your breathing any better? I'm evaluating the dyspnea, the difficulty breathing. Also evaluating the respiratory rate. I'm putting my stethoscope on and evaluating that lung, or the lung sounds and the gas exchange, okay? Let's say you go in and the client is on 3 liters of oxygen because you just put him on 3 liters. You go in later and he's setting at 100%. What do? You lower it and see how they do with it. right? So that's titrating. You can raise it and lower it based on what your assessment findings are. Yeah?
And are you assessing with the pulse op or the ABG?
Great question. You are assessing with the pulse oximetry at that point. If your patient starts to decompensate and you put them on 3 liters of oxygen and they're getting worse, that might be the time that you will want to get an ABG, arterial blood gas. But again, that's a dependent action, not an independent action. I was trying to make the distinction between independent and dependent. Dependent means you need an order. You need an order for chest physiotherapy. You need an order for that 3 liters of oxygen. And you wouldn't lower the bed, lower the bed to the lowest position. Okay, you wouldn't lower the head of the bed, right? You would raise the head of the bed. And I didn't say that earlier as an independent action. That's probably one of your very first things before you even put a pulse ox on them. Let's see if I was smart enough to do that. Here we go. Dependent and independent. I'm going to post this too so you have this, but here we go. Independent nursing actions. Let me make that bigger. Okay, so these are all independent. You're going to assess the patient. You're going to look at the respiratory rate and the depth. The work of breathing should be up there too. You're going to auscultate them. You're going to elevate that head of bed, change the position. With people that have COPD, a lot of times they'll be in this tripod position where they're trying to expand their lungs and they're leaning over a table. That is a really good independent nursing action to tell your person to do. And also, if your patient is doing that, that's indicating that they're having a hard time breathing. They're trying to get more oxygen in, right? Pursed lip breathing, deep breathing, effective coughing. Those are all things you can teach your patient that are independent. You want to make sure that you're assessing whether they're coughing things up, which is a productive cough, versus a non-productive cough where they're coughing and everything's staying in the lungs. Fluids here is an independent, meaning oral fluids, drinking, and IV fluid would be dependent. All right, limiting exposure to perfumes, cleaning chemicals, practicing good hygiene is a great independent activity. And then encouraging activity gradually or clumping activity with rest periods. People that have COPD need to be encouraged to be active, but they're also going to have activity breaks. And you as a nurse need to know that if your patient is having difficulty breathing and is having an exacerbation of their COPD, you're going to want to cluster your care so you don't exhaust them too much, right? You're not going to want them to do a couple laps around the nursing unit if their oxygen saturation is 85 and they're struggling and tripoding to breathe. Or their number one hierarchy need is we're going to want to get them breathing, right, before you get them active. Make sense? As opposed to dependent interventions. So your vital signs, your INOs, your labs, all these medications, and this we're going to look up after break so you know, and analgesics for the fever, okay? Those are some more dependent interventions to improve gas exchange. See how oxygen therapy is there under dependent because it is an order, but as we just talked about, you can give a little bit before you get the order. Pulse oximetry is actually an order too, but it's a nursing intervention in the real world that will put them, and the vital signs, you know, we'll go assess vital signs without an order. Is any confusion on that? Independent versus dependent? Does anybody have real life experience with any of these gas exchange conditions that they want to share or talk about or have experience? Yeah. Uh-huh. Uh-huh. Really? Okay. Pulmonary rehab. Okay. Okay. He was an old guy? Yeah. Did he have the big home oxygen thing and then the tubing that, which is a fall risk? Yeah, thank. Did he trip over the tubing? Okay. All right, that's a good story too. Did he, Asia, right? Asia, did he, when he was sleeping, did he sleep elevated? Did he sleep flat? Okay. So I have a brother-in-law who he's in his 40s and he's on home oxygen and has one of those beds that, it's not a hospital bed, but it's one of those number beds that go up and down, and he's constantly sleeping with his head of his bed like this, and he's got the oxygen tubing in out. They actually just put in a pool down in Florida, and in the cement or the brickwork, they kept a little gravet or whatever area so his oxygen tubing could come along the pool. I know. I was like, yeah.
What condition does he have in 40?
So he was born with an emphalocele, which is his entire intestine, everything in his abdominal cavity was born on the outside of his body, which I used to see at Hopkins. I worked at Hopkins originally, and way cool, but not good for.
Yeah.
So they put it back in, and he is probably 1-to-1 when you measure him. He's got a barrel chest because he doesn't have enough room for his lungs to expand. So his lungs are probably at 30% efficiency, and he gets completely out of breath whenever he walks from like the car to the house. So it's because he was born with that, but he also had leukemia, just got diagnosed with esophageal cancer. He's not a healthy individual. He also eats very poorly, poor nutrition, and does not exercise, poor activity, which also can contribute to that kind of lifestyle at 40-something. I love him dear, but good question. Thank you. Anybody else?
I had to go to the pulmonologist like twice a month with the kids.
Did you?
Now I go once a month, but we would do this spirometry test.
Mhm.
You like sit in a little thing, I don't know if you guys ever done it, like you sit in a little like box and they're telling you to breathe, and I'm like sitting there like push, you can push, do it, push here. And I'm like, no, I literally can't, that's why I'm here.
Right.
So I used to hate it because they would be like, here's the level, you need to get the little ball too, and I'll be like, it's not gonna happen.
Yeah.
I can't do it.
So are you talking the incentive spirometer, or are you
No,
talking the
the
actual
The
spirometer
actual
function test?
spirometry function test, yeah. They made me do it every single time.
Yeah.
And I hated it.
So that's a diagnostic tool, the spirometry or PFTs, pulmonary function tests. And when I worked at Kaiser, I worked at adult health, Kaiser outpatient, and we would have the patients come in and they'd have to stand up, take a deep breath, exhale it all, and then it's this like a peace pipe smoke thing, and you have to forcefully exhale that air, and then it gives you a number about what their volume is, and it'll tell you where they are on the spectrum, on the continuum.
Like a little graph, and I was like, this is the line you want to be at, and I'm like, right here.
Yeah.
All right, well, thanks, guys.
It's a test I'm not going to do well on right now. Yeah, good. Thank you. Thank you guys for sharing. I think it helps when you can tell some stories that make sense. All right. So it is 9:05. Let's come back at 9:20. I'm going to run to my office and I'm going to find out about that leukotriene modifier. All right. I'm also going to open up that case study so you can download it. We're going to do it a little bit differently, but I think it's going to be super fun. She's like, I need to
can you repeat the answer, honestly? On the PowerPoints that I put in this E2L, I also added a video link. You know, see that?
Yeah, it wasn't.
The exact same thing, I'm just wondering if people like the video, would watch the video, or is it just the not?
I did.
You watch the video?
Yeah, I did.
So you would prefer that?
Yeah.
Okay.
Especially in that video, you know, like sometimes when it's a PowerPoint, I can't watch it on my phone, but I'm not doing it because I'm working.
That's what I was told, yes. You can watch the video on your phone, or you can listen to it when you're driving, or, you know, whatever. Right. Okay, I'm good. Okay, so good, good.
Yeah, that's what it is. It's never,
No, it was like, Wisconsin High School.
yeah. I know that,
Yeah, I think
you can't listen to it. When I was in the classroom, when I was in the way you try to listen to those, like, I don't know, one or something like that.
I like to speed it up. Sometimes I like it faster. You do that on YouTube.
Even I was driving a bus, listening to this first part, and you were speaking.
Yeah.
Oh, yeah, especially she did like the factory, yeah. She was so positive, she's
I know that.
Girl, she just be reading all the things. She's like, no, this one of the video works, so let's, yeah, I just went through this one. I don't know. Yeah.
I know, that's why I stopped listening.
Me too.
Honestly.
Especially if it's like an hour. Yeah. It's too slow. But her, now she's really big. I can watch me this not do like more like something which she's not reading, she's asking because
I don't like it. No, she was so baby soft at the ball.
yeah, she
Was
was.
so
Where
Yeah,
was
I know, that's what we really. Yeah. I had a friend, she told me that, she's in the second semester, and she said the one assessment is going to be like a book. Yeah.
The one who,
I wish she narrated the PowerPoint, because I think she explains everything.
yeah, she takes the time.
Yeah.
Like she, even though she just do it, it's just very.
What time was this class
Start this morning or right now?
Oh,
It comes back at 9:20. 12. I think today we're ending at 11.
Yeah, it might be.
No, you're starting.
Just a couple minutes.
No, I was doing stuff that got split down.
This Labor Day weekend, it's your time.
There is a huge fundraising there.
And is your office over there in H?
It is.
The new H?
Uh-huh,
Are you on the hallway with the rest of them?
I am.
Okay. I didn't know, but I won't try to take care of the problem.
Oh, I didn't know there was, oh, no, I'm in H, I'm not in W.
Oh, You
You're
know,
talking W's
yeah.
problem.
Yeah.
I don't have that problem. Good,
Yeah.
I'm glad you're gonna work on it though, bless their hearts.
Yeah, they got one, other parts of the, because of the winter months,
I bet.
and it drove me crazy for a long time.
I bet.
finally got what I was looking for. It came out of me when I opened up one of those drawers,
I know.
like Superman.
I bet.
And I was
Yikes.
like,
I bet.
my heart stopped for a second.
I bet it did.
I'm not scared of him, but when I don't hold there.
He surprised you.
Yeah. Exactly.
Oh.
I'm not going to depot and get something that's a catch release. I'd rather do it that way. I think it's more than, you know.
Yeah.
than the sticks and stuff.
When I was a little girl, I lived in Ohio, and we had a rat, we did a sticky thing, and the pig squeaked and squirted. I still have nightmares. I'm like, oh no.
I was able to get them off of it.
Yeah.
A lizard on one.
Did you?
Last year,
Did you?
I put olive oil on it, he squiggled.
Ah, we
And
did.
he finally squiggled.
You put olive oil on him?
Yeah.
That's cool.
I had, yeah, you can use that, that'll detach it.
Uh-huh.
And the stickiness of it.
That's good to know.
Good idea.
Bye. Thank you.
Yeah, it would be fun. Yeah. I was thinking like I have like a pool and a pond and stuff. I like a party, you know, like grandma. Oh my God, I'll make everything.
Got really excited. I do.
I love how you like, wait, no, yeah.
I love Tristan. I don't like them too. They have a cilantro. Oh, you spread butter on it? Yeah, spread butter. I think it's very strong like that. Like I literally died of What?
And so my stepdad, he goes, she inflicted a great amount of pain on me. When this medical malpractice and then my grandpa calls me, be careful, she goes, and then and then my grandpa goes, be nice, so it happens to somebody else. And he goes, and then like everybody goes, I'm not sure she wasn't in my bill, but she was in your luck. I was like,
I don't know. Really? I know, so that's what. Disturb their natural balance.
Okay, you guys ready? So I wanted to show you an area. Online that you may not know is there when you go to any of your courses, but when you go to our course here and you click on this More button and go to this Kaltura course library, there's different videos that are here. Well, these ones, right? I'm showing you because I know. These ones I just added, and it looks like I'm missing COPD. Oh, here it is. No. So I was talking to the ladies that were here over break about the video. So the PowerPoints that I added on D2L, I was given some feedback that the upperclassmen students really like the videos of the PowerPoint so they can watch it on their phone or listen while they're doing something else. So I uploaded all the PowerPoints in the different areas. And so I'm sorry there's so many of them, but the person who taught it last time had 150 slides on the one. When I tried to put it in one, it was like 80 slides. And I thought, I'm tired of hearing myself talk. I can't imagine how you guys are getting through them. So I cut them up. So there's an overall one, and then there's the different exemplars. Okay, so the PPTs, the PowerPoints are on D2L, as are these links to the videos. And it looks like I forgot to add one more, but I will. So this is just, these are some good videos that I've uploaded, and I'm going to show you a couple of them, but I think it's good to watch. I found this. So let's watch it, shall we? I haven't watched it yet, but I also want to show you these Picmonics on LWW. I was hoping they had a Picmonic on this, but they didn't. So I found this. So let's see. I have no idea what it's going to say. So you know how lawyers are not supposed to ask a question they don't know the answer to. Let's see. Y'all can help me on this. And don't throw me under the bus if Dr. J says, why did you show them something that's completely inaccurate? But I think, let's see what it says. If we can get a volume.
You're gonna have to click on the video itself.
You see the little, like, the sound thing next to the pause on the left, bottom left?
Bottom left, this one?
Yes.
Oh, she's got quite an interesting accent. Okay, hang on.
Flows through the other pathway of arachidonic acid metabolism, which produces nucleotrides. Icosanoid production starts from the phospholipid bilayer of the cell membrane, where phospholipase A2 catalyzes the release of arachidonic acid from the phospholipid molecules. This 20-carbon polyunsaturated fatty is the main source for all biological icosanoids. Arachidonic acid can be engaged in either prostaglandins and prostacyclin or leukotriene production pathways, which is started by the action of 5-lipoxygenase enzyme to produce intermediate 5-HPETE, which is further modified by the same 5-lipoxygenase enzyme to produce leukotriene A4. LTA4 gives rise to either LTB4, LTC4, LTG4, or LTGE4. Then these leukotrienes bind to the cellular receptors to induce various biological effects. Note that the number 4 in all leukotrienes refers to the number of double bonds in the main scaffolding of leukotriene molecules.
That didn't help me.
Indeed, leukotrienes have a wide range of biological roles.
Oh, here's the biological role.
They are important inflammatory mediators, as they enhance inflammatory neutrophil recruitment and extravasation, and increase vascular leakage. Additionally, they play negative roles in bronchial asthma, as they induce bronchoconstriction and stimulate mucus production and accumulation in respiratory pathways. Going to leukotriene pathways, you will notice that the drug solutol interferes with 5-lipoxygenase enzyme, thus inhibiting the production of all inflammatory leukotrienes. Finally, zethyleucas and monteleucas drugs are selective competitive inhibitors of leukotriene C4, D4, and E4 receptors.
I don't love that.
This video was narrated by Alexandra Daniela.
That's actually on our API.
Oh, it is?
Yeah, everything they said, I was like, oh wow, this is everything on there, and I didn't understand it.
Do you understand it now? Okay. That's all I can do on that.
I mean, that helped a little bit.
A little bit. I mean, I'll keep looking if there's something else I can find that might be
It's
helpful.
just like membrane permeability, and it calls neutrons.
I think that's,
I found this, I sent it in a group chat.
Oh.
It says, Leukotriene modifiers, which is what singular is, may be used for treatment of certain conditions, with an allergic response. Leukotriene modifiers have action of the leukotrienes in the body. Leukotrienes are substances that are released from mast cells.
okay.
These substances cause airway constriction and increase mucus production, swelling, and inflammation in the lungs. This causes symptoms of wheezing, cough, postnasal drip, and shortness of breath. So that's why they would need the modifiers to treat.
So the leukotrienes cause cause the constriction and the mucus production. So you need the modifier to make those leukotrienes stop constricting. That help? All right. I want to also show you guys this just because I think this is a little bit longer, the struggling to breathe, COPD. It talks a little bit about that pulmonary rehab that Asia was talking about and trying to get the clients that have COPD to do diaphragmatic breathing and improve their oxygenation. I'm trying to think which one I liked better. I think this one. To give you an idea of what that looks like.
You can see his breathing.
Can you guys see that?
See what's going on with the ribs? Do you know what it is?
Dr.
My name
Leah.
is Dr. Carlo Jet. We're certified nurse physician.
See how he's breathing, and can you see that? Is that light bad? Yes, I can, or no, I can't? Yes, okay. I don't care really what they're saying. I just want to make sure that you can see what that looks like when someone's struggling to breathe. This is that, so your attractions, you have sternal, supra, which is above, sub, which is below, and nasoflaring, and his whole abdominal wall is trying to help him breathe there.
The echo stethoscope.
That's the wheeze. All right. See how it's like a whistle?
That's how you can see the retractions. We wanted to
I
have
like
the
his
information for the tree. To keep the memories there.
Huh?
Other things we do is we increase the decadrons and amigos, muscle fibers, so that they're all contracted and tight in an airways.
All right. And then I like this one too. I don't like it, but. See those intercostal, see that, bless you. See how he's struggling right here where my mouse is? And then the other thing I wanted to show you was how this young man.
It's a disease that affects the lungs and can eventually make the otherwise unconscious effort of breathing seem almost impossible. COPD, or chronic obstructive pulmonary disease, can do damage for decades without giving any noticeable signs that it's there until permanent and irreversible damage.
That's the home oxygen with the humidity. Humidity liquefies the secretions.
But as the disease gets worse, patients are more and more restricted. And the real severe cases, people are really limited, are so short of breath that they can't do anything else other than just sit in a chair, watch television.
72-year-old COPD patient Marvin Tibbetts describes how it feels to lose his breath.
You know, real fast, it's just like that. If you could visualize yourself underwater, and you have all of the air in your body, and you need breath of air. It's not there.
In the United States, tobacco use is a key factor in the development and progression of COPD.
Probably about 90% of patients who have COPD have a pretty clear history of cigarette smoking. It's been estimated that between 10 and 20% of patients who smoke regularly get COPD. But everybody who smokes is at risk. There are very good studies that show that if you are able to get people to stop smoking, the disease course will not
not go back to normal. But the deterioration of lung function over time may not be as bad.
Here is a typical example of someone who starts smoking when they are young. At age 18, the lungs are grown and completely open. No damage is evident. By age 28, there is a consistent cough, sometimes called a smoker's cough. By the mid to late 40s, lung function is beginning to be seriously impaired, and there is difficulty breathing with some simple tests. By the 50s, people who perform physical labor, for instance, find it hard to continue this kind of work. And most COPD patients can't walk for long distances and can't lift objects. By the late 50s or early 60s, quality of life is severely impaired. COPD patients, assuming they continue to smoke, cannot do much of anything in the way of physical activity. The standard treatments for COPD are medications called bronchodilators. Their main job is to help keep airways relaxed so airflow can be increased. These treatments won't restore damaged lungs, but they can definitely improve the symptoms of COPD. In addition, patients are encouraged to use pulmonary rehabilitation.
Pulmonary rehab is a combination of exercise and education that is geared to promote self-care of patients with pulmonary conditions, because there is no cure, but we don't want the condition to get worse and then reduce their quality of life any further.
It's not giving me any more breath, but it's teaching me ways that I can breathe better. And I'm breathing better today than I did yesterday before.
But the bottom line here is simple. People need to stop smoking.
It's time. It's terrible and horrible to stop because you think of it. But you have to want to stop. That's the key. You want to stop. And I've asked people to stop till you get sick.
It's clear. The dangers of smoking must be communicated long before people pick up their first cigarette. Hopefully, as the number of people who smoke decreases, the probability
See how
of
he's
patients
barrel
suffering
chested,
from
see how he's kind of,
COPD
his
will
whole
decrease
thorax
as
is
well.
like, has hypothesis. Did you guys see the nebulizer that was, so that is a way to deliver the bronchodilator, the albuterol. It's also a way to deliver other medications as well. But I want to make sure you know the difference between the nebulizer and the inhaler. So the meter dose inhaler, most of the time, the people that use that have a spacer attached. Have you guys seen these? Okay, so gives the same medication, but the difference is that nebulizers usually hook to the airflow meter, cranked up to 10 so the mist is forcibly going into the lungs versus the inhaler, or yeah, the inhaler that you use with the spacer. Make sense? Okay. I'm gonna check who's here. Mrs. Ray just asked me to, but before I do that, oh, you're stretching. Ooh. What do you guys think about these picmonics? Do you think they're stupid? And they're quick.
This picmonic will help you recall important facts about albuterol, also known by its trade name Proventil, and it's the story of Ab Butter Troll, who's a singer and dancer that gets all the ladies swooning. His backup singer, the beta fish Choo-Choo Dragoness, holding a short ruler, represents that albuterol works as a short-acting beta-2 agonist. His music is coming from DJ Broccoli's spaceship, which represents that albuterol is used to control bronchospasm. The troll uses his asthma inhaler to whip back his hair, signifying that this medication is sometimes used for acute asthma attacks. Side effects may include angina, shown by the angel with chest pain overwhelmed by the outstanding performance, or tachycardia, the tach heart card pinned to her chest. It is also possible to experience tremors, shown by the trimmer some fans use to cut off locks of the troll's hair to keep because they're so obsessed. So to summarize, albuterol is a short-acting beta-2 agonist indicated for bronchospasm and asthma. Side effects include angina, tachycardia, and tremor.
All right, so during your assessment of a patient taking albuterol, which of the following side effects is most likely to be seen? Just shout it out. Increased heart rate and dysrhythmias can occur in patients who exceed the dosage, makes them very hyper too. And I've had a child on it. Okay, next question. Where? Thank you. You guys are so good to me. Which of the following is most likely an indication of the use of albuterol? Bronchospasms, because it relaxes that smooth muscle in the airway caused by the beta-2 receptor activation. Can prevent or relieve bronchospasms. What mechanism of action or pharmacological action is best associated with albuterol? You got it. Albuterol activates the beta-2 adrenergic receptors in the lungs, causing relaxation of the bronchial smooth muscles and subsequent bronchodilation. It has little effect on that beta-1 cardiac receptors when taken in small doses. Can be administered using a metered dose inhaler or a nebulizer like we just talked about. This is the picture of the inhaler. Okay, during your assessment of a patient taking albuterol, which of the following side effects is most likely to be seen? Chest pain associated with inadequate oxygen to the heart is called angina. In some patients, albuterol has been reported to cause or worsen this. Patients should contact their primary health provider if they have worsening of chest pain. How about during your assessment of patients taking albuterol, which of the following side effects is most likely to be seen? Tremors. Okay, and that is, it's just, okay, next question. Last one. Which of the following is most likely an indication of use? Asthma. Okay. I just think these are really fun and they're quick. You can actually go in and look at any of them. You don't have to have it assigned. If there's something that you're trying to understand a little better, again, I thought it might have it has different medications in here. Okay. All right. So if you go into gas exchange in-class activities right here, you'll see these. Okay, click on that one and you should be able to download it. Where did I put the Word document? Because that's just a PowerPoint. Please, is it in there? Okay, hang on. Let me get out of my student view. Please hold. Oh, that's going to make me so mad if I don't have it. Talk amongst yourselves. Hang tight. Talk about patho if you want.
Immunocompromised. Comes up ACI. Blood transfusion. Got it. Yeah, it's not ACID.
Okay, thank you guys for your patience. So if you go into gas exchanging class activities, the very bottom one is going to give you the Word document that you can download. Everybody with me? So gas exchanging class activities, the very last one there. Those of you who want a paper copy, like I said, I printed out 15 of them. I'm going to let you guys do this on your own. Come on up and get the paper copies if you want to. Well, you know what, I guess with COVID, I should probably bring them to you. Sorry. And then I'm going to pull it up in the PowerPoint too. All right, raise your hand if you want a paper copy.
Oh, sorry. No, you're fine. I didn't grab it right. Look at you.
Okay, so this is how we're going to do this. Go ahead and download that document, or use your paper one, and then I'm gonna open it up this way too. Okay, so Joanne Walker is an 84-year-old female who has a productive cough of green phlegm starting 4 days ago that continues to persist. She was started 3 days ago on prednisone 60 milligrams PO daily and is Zithromax 250 milligrams PO times 5 days. Though she has had intermittent chills, she first noticed a fever last night of 102. She's had more difficulty breathing during the night and has been using her albuterol inhaler every 1 to 2 hours with no improvement. She called 911 and arrives in the emergency department by ambulance, where you are the nurse who will be responsible for her care. Here is her personal social history. She was widowed 6 months ago, was married 64 years to the same man, and resides in assisted living. She's a retired teacher, and she called her pastor, who has now arrived and come back with the patient, and the nurse walked into the room to hear the pastor ask Joan if she'd like to pray, and the patient said, yes, this may be the beginning of the end for me. Bless you. So what I want you to do first is write down what relevant data you would think is clinically significant in both of those areas, in the present problem or the personal social history. So what is relevant? You should have that information in front of you, either on paper or in the document, okay? Thank you, Mark. Raise your hand if you're done. Oh, you went ahead, huh? Okay, let's do this real quick. Let's go ahead and talk about what significant. Okay, so significant data from the history. Productive cough of green phlegm for 4 days. Okay, so it's always a red flag if that sputum changes colors. It goes from yellow to green is typical, showing you that there's dead neutrophils and that they've responded to a bacterial infection. That she was started on prednisone and the antibiotic 5 days ago, and knowing that she is progressing into more of a respiratory distress. Okay, everybody get those two? What other two did you get? What's another one you got? Fever. Fever and chills, right? So make sure that you realize that the change of the sputum color and the elevated temperature is relevant, because that's the body's immune response trying to fight that bacterial infection, okay? Because that first responder is the neutrophils to increases that production so that we try to fight that inflammation. That she was having more difficulty breathing during the night. So that's very true on people with COPD and asthma. In the night, their cough gets worse. They have a more difficult time breathing, and knowing that she has a history of that COPD and pneumonia is causing the difficulty of her breathing, okay? What about the social aspect? What relevant information did you identify in her social history? Okay, assisted living. Why is that important? Right, she's around some people that possibly, I don't mean to say hygiene, but yeah, and some germs, and sometimes people in assisted living have less cognitive abilities. So that, yep, assisted living. What else? She's religious. She's religious. So what did you guys think about when she said, this may be the beginning of the end for me? A sense of doom, and that is impending doom. That is something you never want to discount, right? So if a patient says to you something like that, you can't ignore it. It's widely reported that is, they kind of know what's going on with their body. So that, and the idea that the pastor wants to pray with the patient. How do you guys feel about praying with your patients? You think it's awesome? You wouldn't do it. Two extremes. How come? Neither are right, neither are wrong.
That's not my religion. Outside of my comfort zone.
Outside of your comfort zone. Yeah, you can talk about things that you can relate to a lot easier. So I was working at Children's, and I had this necklace on, and I wear it all the time when I'm stressed or worried. You know, it's a tactile, you know. So and it's a cross. I got it when I made my first communion with my kids, And I remember really distinctly a gentleman, a Hispanic gentleman, I was taking care of his little girl, and I had this cross around my neck, and he said, "Hey, what does that cross mean to you?" And I completely froze. You know, like he was trying to make a relationship that we both had the same religion, but I felt uncomfortable talking about it because I just wasn't raised like that. Now, someone else might feel comfortable doing that, and I encourage that if that's a two-way relationship with your patient. That's okay. So hear me say, it is okay to pray with your patients if they ask you to and you feel comfortable, okay? You don't have to. It's not a must, but you do need to recognize the religion and spirituality in your patients, okay? Because religion and spirituality aren't always the same thing. I had a friend who was a nurse who always would say, I don't follow a religion, but I'm the most spiritual person you will ever know, you know? So that's my 2 cents on that. All right. Let's do this. The next question, we want to know, what is the relationship of your patient's past medical history and current meds? So which medication treats which condition? So I want you to kind of do arrows to tell me which medication treats which condition. Yeah.
What if we don't know any of those?
We can go over it together. You want to do that?
I just don't know.
Okay. So okay, let's start. So fluconazole, this Advair is, so let's go to the next slide. It'll give it to you. Can you see that? Do you need me to make it bigger? So this first one is an anti-inflammatory, control of that asthma COPD. That second one, albuterol, Ventolin, MDI, is a bronchodilator, improves ventilation. And I'm gonna, the lisinopril is for hypertension. It's an ACE inhibitor. It's gonna decrease the lady's blood pressure. The Lopid is for her high cholesterol, her hyperlipidemia. So the expected outcome is that her cholesterol will go lower. Diazepam, Valium, is for anxiety. And Diazide is a diuretic, and that's also used to decrease her blood pressure. And you'll get more into that, right? So the COPD and asthma, she would be on these two here, the top two for the COPD and asthma. The hypertension is being treated by lisinopril. Cor pulmonale is the right side heart failure, right? So when somebody has increased pressure, tension in the lungs, it's going to make them more susceptible for that right-sided heart failure, which is being treated by all of those, really, because by the bronchodilators, the anti-inflammatory, and trying to keep that blood pressure down, okay? And actually, this one actually talks about what I just said there. Questions on that? You feel good? Mm-hmm. Sure, yep. This one? Okay. Yeah, I'm going to have all the answers online. Yeah, but sometimes people, like, I learn better when I write them out. And hopefully seeing these now before you learn them, and patho-pharm might help. Tell me when you want me to move on. What I said was cor pulmonale is that right-sided heart failure, and that condition will warrant the anti-inflammatory, the bronchodilator, that ACE inhibitor, the diuretic, because the ACE inhibitor and the diuretic is going to decrease that blood pressure and the tension, right? And the other is going to improve the lung capacity. that make sense? Shoot, I brought my beach ball. I was going to throw it at you guys to have you answer questions. Forgot. I just looked over at my candy and beach ball and thought, huh. I went all, well, I also was looking for the answer. But yes, I did. Okay, you guys good on that one? Okay. All right. Okay, so the next question is that one disease process often influences the development of other diseases, other illnesses. Okay, so which problem likely started first, and then what past medical problems followed as dominoes? So going back to the past medical problems, right, these ones, which one likely started first? Yeah, I think you're not even gonna let me play. Smoking, right? Smoking. And then what then followed after that? COPD and asthma, yes ma'am. Yep, then causing the hypertension. The core pulmonale would be before the hypertension. It probably could be conditionally together. All right, so because he's a smoker, she's a smoker, that is what probably started the rest of it. So smoking, then COPD, asthma followed, then the core pulmonale, because that's a result of the increased resistance of the right ventricle that needs to overcome the pumping into the lungs. Hypertension, because of the smoking, and then hyperlipidemia. Look how tiny the IA is. Okay, we all on the same page there? Okay, now let's look at our patient's vital signs. Have you guys been taught cold spa yet? The pain assessment tool? Okay. So I converted it a little bit to add to cold spa. All right, so you guys good on that? You're going to have that in front of you because I want you to tell me what data from the vital signs is important and relevant and therefore significant to you as the nurse. So looking at that vital signs. Yes, Cheyenne.
I have a question that's not really related to this, but is related to pain
Can
scale.
always ask a question.
For our assessment, we like kind of found out through other classmates that we're going to have to ask about pain. Like, how do we do that in our assessment? Like,
Sure.
So what are we supposed to say? Are we supposed to ask all of this kind of stuff?
Yep, that's a great question. So pain is your fifth vital sign. The pain assessment is your fifth vital sign. And it's always something like this. I'm going to role play with you. You ready? Okay. So Cheyenne, are you having any pain today?
Oh, yeah.
On a scale of 1 to 10, 0 to 10, 10 being the worst pain you've ever felt, 0 no pain, what number would you rate it? 6 or 7. Oh, okay. So where is that pain located? Your lower back. When did it start? What was the onset of it? When did you start feeling that pain?
It's been on and off for 20 years.
Wow. Wow. Is when it starts hurting, how long does it last? Weeks. Is there anything that makes it better?
Chiropractic.
How about worse? Anything that makes it worse?
Sitting for long.
You may all clap for both of us. So that's how that is. Okay. And it's just, I mean, it's just a conversation. So did you see how I went down that cold spa character? What did you say it was? Or maybe I didn't ask you the character. Oh. Is it stabbing? Is it aching? What's the character of it?
Super achy.
Super achy. Onset, you told me 20 years ago. L, your back. D, your duration. You said intermittent when it comes to severity. You said first, I asked you first, was it 6 or 7, I think you said. Cold spot. P. P is kind of for precipitating factor is alleviating. So like what makes it worse, what makes it better. So that's how you ask that.
Okay. So that's what we need to do.
You do.
Okay.
You do. And so depending on the situation. But you always have, I mean, the number one thing I ask, are you in pain? And then the scale, because that severity is really going to depend how much farther you're going to go into it, right? So if I say, how bad is your pain? And you say it's a 10 and I'm having chest pain, where is your pain? In your chest? We might go differently, right? But if it's back pain, it's a long-term thing, you're going to go down all of it because it's going to help you figure out your interventions. That was a great question. I loved role playing it with you too.
And then,
Yeah.
so if they say like no pain, we don't
Mhm.
need to go
Then you don't have to ask them the rest.
in our
Mhm.
assessment, in our
Yeah.
validation.
Yeah.
Okay, cool.
Yeah. Oh, it's a validation thing.
Yeah. it's a
Okay,
validation.
perfect. So when you all knock that out of the park, I get to validate you now. So I'll know. So if you're on my list, I'm going to be like, what's your cold spot? I know we talked about it. Okay, good. So guys, did you have a time to look at that? Or what data is significant? Okay. Okay, so you're saying the oxygen sat at 86% on 6 liters of oxygen via nasal cannula is significant, and I would agree with you. And it's elevated because of the hypoxia, right? So elevated due to underlying hypoxia, infection, pneumonia, and difficult for that gas exchange. You must notice, and we haven't talked a lot, actually I did on my PowerPoint, 6 liters is absolutely the highest you're going to want to go, and you should have something attached to that 6 liters that gives humidity, because it's going to be very drying, right? So I heard somebody say fever. Yes, Laura.
The oxygen stat is elevated?
The oxygen saturation is low. Sorry, that's a typo.
Okay, so it's definitely not elevated.
It's definitely not elevated. I'll fix that before I post it. And my small little IA. Okay, so oxygen. Yeah, because what's normal? You got it. Thank you for pointing that out. Okay, and then I heard somebody say temperature. What else? What else is, before I hit that next slide? Temperature is indicative of that inflammatory process. What other vital signs are concerning to you? The blood pressure. Why is the blood pressure concerning? It's high, but she has hypertension. Any other reason that might be high?
The difference between 176 and 98 is really great.
What were you saying?
Anxiety.
Anxiety. She's stressed. She can't breathe. And her body's trying to compensate. It's higher, and she has hypertension. Okay. What other vital sign is kind of shouting out to you? Respiratory rate. What's her respiratory rate?
30.
30. And what did we say earlier was normal for normal people? Don't ever use the word normal. That was bad. Yes. So 12 to 18, 20, whatever. 30 is pretty fast. Why do you think her respiratory rate is high? She's got tachypnea. Why? Because her oxygen saturation is low and she's exhibiting an early sign of hypoxia, right? Okay. What about her heart rate? You know, it really depends on who was it that was, somebody was taking my blood pressure in skills lab and was like, wow, or my heart rate. Wow, your heart rate's low. You know, is that normal for you? Always got to know what's normal for your patients. I had an athlete who was 18, 17, stinking A. When he fell asleep, his heart rate was in the 40s. And, you know, for somebody that's not athletic and, you know, an 18-year-old, that would be concerning. And we actually had to do something with his monitor because it kept going off. But you have to know the norms and how it's trending, okay?
What if they tell you it's normal and it's still really low and concerning?
So then I would assess them and see if it's impacting them in any way. So are they able to perfuse with that low of a heart rate? Or do they, you know, so how do you find that out? How do you know if they're perfusing? You look at their color, hopefully they're pink. What else? You look at their, yeah, so if they're, so the clubbing or were you saying for clubbing or were you saying for color? Color, right. So if they're pink all the way through, you feel pulses, which I know we haven't talked about that yet, but you would assess them and make sure they're perfusing fine. And if that's okay, then that's all right. That's what they're at, right? Absolutely. Why would you do that, Gavin?
Because if oxygen's being delivered like correctly, your oxygen saturation will be.
Right, so you can't, I mean, think about it conceptually again, guys. You can't really take the two away because you have to have perfusion, you have to have blood flow to get that oxygen to the tissues, to get it all the way to perfuse the body. So yeah, those are interrelated concepts for sure. And then chest pain. So she's complaining of chest pain. You always have to investigate that because we want to know what's causing that chest pain. For her, most likely, what's causing that chest pain?
Not being able to breathe.
Could be those things, could be tightness, not sure, pulled muscle, so it's more, it's what we call pleuritic pain. So remember, you have that pleural lining over the lungs, and when it becomes inflamed, pleuritis, it becomes inflamed, there's pain associated with it, right? Because inflammation, that's part of the character, yeah. Sitting probably hurts your back too. It's only one patient.
Okay, so if she's coughing a lot, wouldn't that cause her pain in her chest?
Yes, so it could be, it doesn't necessarily have to be a pulled muscle, but it certainly would be that pleuritic pain. She's coughing a lot, it's irritating those tissues. Yeah, yep, absolutely.
I was gonna say, she remember, I was like, I had someone that old and they coughed a lot and they had a fractured rib.
Wow.
Because they were coughing so hard.
Because their bones are more frail, and yeah, for sure. Yeah, yep. Or, my husband has this, don't tell my told you, has this umbilical hernia thing, and he's been coughing a ton too, and every time, yeah, so it gets worse too. So yeah, thanks for bringing that up, Laura. Okay, so we just did what vital signs are relevant. What assessment data is relevant? We can just talk through that. Does anybody see assessment data that's relevant here that we want to talk about?
She appears anxious and distressed.
She does. I like that. I mean, I don't like it, but yes, that's a good assessment to key in on. What else? Yeah, so those intercostal retractions is telling us she's working to breathe. She's wheezing, telling us that she's not getting that oxygen to the to where we need it to exchange the gas to the alveoli. Anybody concerned about the assessment on her heart? Why do you think she might have pale, hot, and dry skin? Could be the hypertension, but it's probably another vital sign. She has a temperature. Laura, you just said that she has a fever. So you're going to see that with hyperthermia, with a temperature that's higher. You're going to see more of a pale, hot, dry look, almost like a dehydrated look, right, with the fever. Neuro-wise, we love that she's alert and oriented ×4, because what's an early sign of hypoxia related to a neurological person? Restlessness, confusion, disorientated. When it becomes more late stage hypoxia, what does that look like? Worsening, more of a change in mental status, more confusion, stupor. Yeah, we had a conversation about stupor, didn't we, Autumn? Yeah. Okay. I'm okay with the skin, and I'm okay with the GI. Abdomen soft, non-tender. We can auscultate the bowel sounds throughout. But I am concerned about the appearance. I'm concerned about her respiratory status. Cardiac, I'm not really concerned about that because I can explain that. All right. Good? Are we good with that? Is this making sense? Okay. Okay, so what is the clinical significance of that? I'm going to give you a couple minutes to work on that on your own before we talk about it. So what is the clinical significance of each of this information that you said was relevant? Okay, so what's the significance of her appearing anxious and in distress?
It can also make breathing harder and heart rate go up.
It can, yep, yep.
Wouldn't it be consistent with the fact that she's struggling, that she's having a hard time breathing and getting in that box?
Absolutely. So again, it's one of those early signs of hypoxia, the combining it with her vital signs, that distress, it's confirming, you know, she is in distress. What about the dyspnea with the intercostal retractions and breath sounds? Very diminished bilaterally with scattered expiratory wheezing. What's the significance there? Mm-hmm. Right. Yep. Right? So retractions have to be considered a red flag because they're present. She's in respiratory distress. The skeletal muscles are being used to help ventilate. Because she has COPD, she may have diminished aeration as a baseline. You don't know that for sure. But the wheezing absolutely 100% indicates that her bronchioles are constricting, they're getting narrower. We talked about this a little bit earlier. Expiratory wheezing is more common, typically indicates less severe bronchoconstriction. When they start having it on inspiration, inspiratory wheezing combined with expiratory can mean severe narrowing and is considered a red flag. Okay. What about, we already talked a bit about the cardiac. I think that's more because of her fever. And then the person who made this case study wants you to also remember that this is, how old is she? How old is
84.
84? So with 84-year-olds, although her urinary tract is looking like it's normal, she's boarding without difficulty, it's clear and yellow, we never, never, never want to forget that a urinary tract infection is usually, can cause things like hypoxia, confusion, delirium on older people. So we just want to make sure we're paying attention to her kidney function. Okay. So, oopsie, that's going to tell you, I totally gave you the answer. Okay. So what's the primary problem that your patient is most likely presenting with? Acute respiratory distress. And we often see that with COPD and pneumonia, right? So that she is in acute respiratory distress. So the next question I'd like you to give a little thought to is, what's the underlying cause, pathophysiology behind the problem of pneumonia? So she has pneumonia. So we just talked the primary problem that she's most likely presenting with. She has pneumonia, which we know that, I think, in the case study. Did we know that, or is that a surprise to anybody? Okay, she has pneumonia, if it didn't say it. She has COPD, asthma, pneumonia, and because of her symptoms, how she's presenting, she's having respiratory distress. But let's look at her with the pneumonia pathophys. So talk to, or write it down, and then we'll talk about what's causing that, and then we'll look at our nursing intervention or diagnoses. Okay. So what, I feel like because I really want to get to the diagnoses. Okay. It's inflammation of the lung tissue. It's bacterial or viral. We would want to obtain a sputum culture, blood culture before we start the IV antibiotics, right? Okay. I love this third bullet point because of the damaged and diseased lungs that the patient has with COPD. She's a susceptible host. Remember, a chain of infection. She's got a, she's more at risk. And then after the organism, whatever's causing that pneumonia, gets to the alveoli starts producing more fluid. That fluid takes the place of the alveoli, doesn't allow that gas exchange. And then when you auscultate, you hear crackling because it's fluid in that airspace, okay? Okay. So let's look at your nursing interventions. I gave you the first one. So there are 3 nursing interventions I want you to write down there. The first one is impaired gas exchange related to lung consolidation with decrease in surface area available for that gas exchange. You understand that? So I want you to tell me, write it down, what the nursing interventions, there are 5 specifically I'm looking for, and why, the rationale for those interventions, and what's your patient's expected outcome. You can talk amongst yourselves if you need to talk amongst yourselves.
There's also a PowerPoint if you need assistance. That's in the gas exchange in-class section. I think it's available to see. That might help you. This link right here. Okay. Guys ready to talk about nursing diagnoses and interventions? Yeah? Okay. So, for impaired gas exchange, well, let's ask, okay, what are the other two that you guys came up with? Impaired gas exchange I gave you. What's another one? Ineffective breathing patterns is a good one. What's another one? Based on the mucus that this person probably has. Fever's a good one. Altered body temperature. Yeah, but there's another one that they can't excrete the secretions. Ineffective airway clearance. He said it. Yay! Ineffective airway clearance. Absolutely. So the top two are impaired gas exchange, ineffective airway clearance. I like the breathing pattern. Bless you. The breathing pattern diagnoses can definitely apply here, but I think with that one more, that's like, well, like, so respiratory rates being too high, too low. I use that one a good bit when, so like drug overdose or medications that's going to decrease the respiratory rate. It's not wrong, but ineffective airway clearance and impaired gas exchange are by far the top two for COPD and asthma, okay? So let's talk about what some interventions would be to improve gas exchange. There's 5 of them.
Positioning?
Positioning, I love it. What else? And by positioning, you mean raise that head of the bed up or tripod to help improve it, right? Okay, what else? Supplemental oxygen, and how do you know how much to give? Per the doctor's orders. So for someone who has chronic bronchitis, emphysema, COPD, we typically want it above 90%. So supplemental oxygen to keep saturations above 90%. Fabulous.
How do you know that they need oxygen? Your assessment, which would include auscultating, yep, auscultating the breath sounds, and also continuous pulse ox, because that's so don't forget those assessment steps, because you never, I mean, you always have to do them in order. So you have to assess, which includes that auscultation, respiratory rate, continual pulse ox, and then that'll give you the information you need on whether they need the supplemental oxygen, okay? And then assessing that respiratory pattern, noting the quality, the rate, and the effort, and positioning, like Evan said, placing them in that high semi-Fowler's position. And why do we do that? Why do we place them in a high semi-Fowler's position to improve gas exchange?
Gravity on their side.
Okay, gravity, what else? It allows the diaphragm to expand. It gives them more room for their lungs to expand, inflate. Yep, absolutely. Okay, so let's look at our rationale behind those. Okay. Oh, that's not. Oh, yeah. And then our expected outcomes. So when you auscultate the breath sounds, that'll give you an idea of what their baseline is, and it'll help you know if they're getting worse or better. Somebody comes in, they have wheezing and inspiration and expiration, and then you listen 2 hours later and they have scattered wheezing. Is that improving or worsening? Improving. Same situation, I'm coming in. Well, that's probably not acceptable. Okay, yep, they're improving. Continuous pulse ox, again, to watch the trend, keep it over 90. Based on what the pulse ox, you're going to give the oxygen. Okay, so let's look at the next one, ineffective airway clearance. So again, think about what that is. You're trying to clear the airway. What are some interventions? What do you want to assess? You want to assess the secretions. What do you want to look at in the secretions? Color, consistency, amount, odor, blah, right? I'm trying to, what do you want to encourage? Coughing, what else do you want to encourage? Sorry, I'm hoping I'm not freaking anybody out. I forgot COVID. So encourage coughing, encourage deep breathing. What's that machine that we use to encourage the alveoli to inflate? The incentive spirometer, yep. And then encouraging fluids. What's the rationale behind encouraging fluids?
Because water breaks up mucus.
Okay, it's going to thin it, right? So you encourage them to drink more fluids, and it's going to liquefy that secretion, which hopefully will allow them to clear their airway. Same situation, that coughing is the same way. What do you mean, when do you not use the word encourage?
I think that's just when you're making your notes. You don't say I encouraged them, you say I gave them 22 ounces of water, whatever. Or
Those are for the team tree. That's what I would treat our like care plan.
Okay. Okay.
So that she didn't want us to use the word encourage.
Okay. All right. So promote coughing, deep breathing, and incentives. Provide fluids. I will change the word encouraged on this PowerPoint before I put it up there. I didn't realize that. I like to be encouraging. All right, and then.
She just meant when we were documenting it, like encourage just gives a vague definition of what you did. She wants more specific of how you did that. I don't think it's, you're still encouraging the client to take the fluids, but
Okay.
in your documentation, you need to put gauge.
Okay. Okay.
Specific amount of water.
It's still an intervention, that's what we did when we used it.
So more on the documentation side.
Yeah.
Okay. Planning. Mm-hmm.
Yeah, our planning.
That last one that I used was altered body temperature. So interventions would be assessing temperature every 4 hours, administering Tylenol PRN, and encouraging oral fluids. Of these interventions, which one is the independent nursing intervention? Encouraging oral fluids, because you definitely need an order for the Tylenol, and you do need an order for vital signs and how frequently you're going to give that or take them.
We need order for vital signs if it's more than your initial one, right? Because you can take vital signs, you can't just keep taking them.
Correct. What you need the order will typically say how frequently to do it. So if someone's more sick, they may be doing vital signs every hour. You're giving blood, you're doing vitals every 5 minutes. They're post-op probably every 15 minutes. So it's more. Thank you for saying that. It's probably more the frequency in which the vital signs you're taking. Very good.
I was like, man, because I've been doing it all wrong.
And
Like,
no one's been
go
giving
and
me
get
an
vitals
order.
whenever I want.
No, and again, it goes back to that protocol, right? So the 1 to 2 liters of oxygen. We have protocols that say when a patient gets admitted, do their vital signs, assess them, right?
I was like, I would get in big
Thank-
trouble if I waited for.
Thank you, Elizabeth. I did not mean to indicate that.
No,
Absolutely.
I just was like, oh my God, I'm doing this wrong.
No, you are not. You are not. You are not. You are not. Okay. Those are my rationale. Okay. What's the worst possible thing for your patient right now? What would happen that would be really, really bad?
They stop breathing.
Right. They would stop breathing. So respiratory and cardiac are 2 body systems that you will always assess no matter what. Perfusion and oxygenation. Okay. The worst thing that could happen is the person would go into respiratory failure and then sepsis shock. All right. Nursing, and I'm going to have this up front. We're running out of time. I'll put it up there so you have it. But respiratory failure, these are some nursing assessments that you would want to do to identify that complication. And then I'm going to tell you interventions. So you're going to want to do an oxygen saturation. BiPAP is a machine that forces the oxygen. It's more of a aggressive. So you're going to start nasal cannula. You're going to go all the way up to a non-rebreather, or if you have to intubate them. Okay. You're going to assess their respiratory rate, their work of breathing, their level of consciousness. All right. And then here are your interventions for that. Somebody in respiratory failure, you're calling a code. You're getting it, you're having your healthcare provider intubate them, you're keeping the airway open. All right, so let's look at 1 hour later. You've been able to implement all your orders that we just flew past. And these are your vital signs, right? You guys are good. All right. Is your client getting better? Here's your recent assessment. So she went from very anxious to resting comfortably and not in acute distress. She went from those inspiratory and expiratory crackles to diminished aeration just in that left lower lobe where the pneumonia is. Okay, so her temperature is trending down, her pulse is trending down, her respiratory rate is trending down, her blood pressure is trending down, oxygen sat is trending up, and she's just generally, her appearance is better. So you guys saved my sweet, what was her name again? I should remember. Joan. Way to say Joan, guys. I kind of whizzed through the end of that because I know you guys might get out of here, but what questions can I answer for you just in the overall? Is it making more sense? Yay, no, maybe? Yeah, okay.
So you said the worst outcomes were respiratory failure?
Respiratory failure.
Cardiac arrest?
And well, respiratory failure will make them then go into cardiac arrest. Septic shock. So septic shock is when the entire body's starting to shut down. So, and that's where we'll talk about it more in perfusion, but septic shock and respiratory failure is going to happen first, and then they're going to get intubated, and then at that point, if they continue to deteriorate, they're going to become septic, and because septic is infection in the bloodstream, so they're going to get worse, and that's
we don't need to stress you about that just yet.
Okay? Okay? You good? I will send wonderful prayers and good thoughts to you. What time's your test tomorrow? At 1. Okay, so let me know what questions I can answer for you, and have a lovely rest of your day. You're welcome. I'm gonna. And I didn't even throw my ball at you guys. Oh, come get candy. Don't let me take this home. Come get candy, please. Yes. Yeah. That is it. Assessment is always independent nursing intervention, and always can be connected before an intervention and after. So that after is the evaluation piece. So, like Elizabeth said, they may tell you assess vital signs every 15 minutes. So that part's in the order. But if you're assessing your patient, that's I'm going to keep doing that. And I didn't mean to say you couldn't use vital signs without a program. That's not how I portray that. You absolutely can use vital signs without, you can't do it less. Okay, so if I had a order that said assess vital signs every 12 hours, and I wanted to do it every 8, you're within your scope. You're within your nursing. You're approved to do that. Right. Right. But in that situation, you would call the healthcare provider and say, hey, I'm holding this medication because of X, Y, or Z. In this, you would just do the vital signs because it's good and competent.
Also, if you're like validating, right? If you're validating if something was off, you can also check behind them. That one's okay. You have an order for that.
Yeah, and what I was saying to Leslie is that I didn't mean to say that you can't do it more frequently, because you absolutely can do your vital signs more frequently. But if an order is to do vital signs every hour and you do it every 4 hours, then you're liable. That's not good nursing care and you're not following the order. But you can always do it more frequently to validate what you're doing.
And then they need more. Did we give them more or did we ask?
Oh, we're talking vital signs or oxygen? You have to get a healthcare provider's order to administer more than that. These are like so, again, it's gonna depend on where you're going. But like in the ER, those are going to be standard protocols, standard orders that say, if the patient comes this, you can do this, right? And you have nursing privilege to follow that out, but you will have to get an order after the fact to cover you legally. Because it's a medication and the physician or prescriber has to. But absolutely never, don't do the care because in that situation with oxygen, because you don't have to do the care.
No, I don't think it's, okay. I don't think it's fair. I don't think it's fair.
And then that's gonna raise the little, hold it, and that's gonna make the LV alive more inflated. So it's gonna help you expand your lungs and help with gas. Heat flow is going to measure the volume in which you're breathing. The nature of heat will depend on what kind of medication. The aesthetic barometer is able to measure the different loaded acids. The peak
it's probably not that information, but it's more of a, an intervention to promote that. Devote boundary out with if anybody whose lungs are not, anyone who's in use, my sample, my daughter, and does very well. Anybody, it's part of pulmonary. But those people, they don't take a deep breath, they don't move around as much, they have an infection. The longer people are lying in bed, they're more susceptible to that infection. I know, but I have to put now. Incentives for owners do not need doctor's orders. You will see them on the order. I'm gonna look that up.
Whenever I go to the doctor, the nurse is just like.
Right. Again, it might be one of those standard protocols that say this is just something we're gonna do. And what was the other question? Oh, the peak flow meter. The peak flow needs an order because, because they have to go get that machine. So yes, I would say probably both of them need an order, but again, a lot of times you'll do that in some just as standard nursing practice. It kind of blurs a little bit, especially now that we're getting into the 21st century. We're more of a profession than we used to be, so we can do a little bit more than back in the day when having to do everything by the doctor's order. Makes sense?
Hey, there's more candy up here. Who wants candy?
Christelle told me she wants all of it.
Who does? Christelle, you want some candy? Good. Here, I'll just put it on the bag. You can take it. You can take it.
Love you, Christelle.
Aww. So sweet. Take the whole bag. Yours. You won the prize.
Yeah. And I've had a problem with the firm. Because like, say like, because if you don't pay with your card, and like, I usually always put my money on my card. Yeah, because like, you couldn't do much money. With that. Yeah. But much money's gone, much money's gone. It's big. Now it's available. So I don't even know what that is. But that's just like. Ms. Dowd, you got any advice for pathology?
I don't. I'm not even gonna BS you.
That's one. My mentor failed.
Your mentor what?
Failed.
How?
I don't know how. I guess it's pretty easy.
Wait. No, I really don't.
I mean, she passed it the second time.
Wait a minute. Say that again. What? Who's your mentor?
Chelsea Strickland.
Oh.
Oh, why you say like that?
No. I thought you meant your teaching your faculty mentor. And I was like, oh.
No.
Yeah. It's a hard course. It is. I'm not gonna lie. I don't have any suggestions for you. I'm sure you'll do great. How's that?
That's what everybody keeps saying.
No.
Even Dr. J. Oh, you'll do it.
Yeah, even Dr. J. Don't you just love Dr. J?
Yeah.
I do too.
So my self-esteem can come further.
Oh, bless your heart.
Yeah. Yeah, I thought the mosquito was Mexico as well.
Yeah, I know.
Yeah, but they're, oh yeah, but they're like straight Mexicans. You can't say it's that's what yeah, I mean, it's just like, yeah, I know. It's just because it's like, I'm looking up. It's just like slime. Yeah, it's not like good.